We've seen more physicians using a transradial approach for neurovascular procedures as opposed to the groin punctures. Studies have shown this is more comfortable for the patient with lower costs and fewer vascular complications. The transradial site is easier to compress, and there is dual blood supply to the hand provided by the ulnar artery, as you can see there. It is a more challenging technique, so that's probably why we haven't seen it come into favor until now. Here's a really simple diagram of the anatomy of the wrist. So our goal with this TR band is to maintain and achieve hemostasis and maintain perfusion. So the goal is to have hemostasis of the puncture site, but we don't want to compress the nerve structures like the median, ulnar, or radial nerves. This is the anatomy of the TR band. So the physician that's doing the angio procedure, they will be the one to apply this band. They'll apply it as they're pulling the introducer out of the artery. The band comes in two sizes. The larger side just has about 5 centimeters more Velcro to it. The air injection port has a valve, which the physician will use to inflate the two little balloons with air right over the puncture site. When the TR band is in place, you will be able to see the puncture site through the transparent plate of the band. There's intentionally space on the ulnar side of the wrist to allow for venous return. And as you can see, the two bands together apply pressure directly to the radial artery while avoiding compression of the nerves and the ulnar artery. So when a patient comes up to the unit before it's time to remove the TR band, we have certain responsibilities as nursing staff. This includes monitoring and recording of vital signs every 15 minutes, including heart rate, blood pressure, make sure this blood pressure is on the opposite arm, radial and ulnar pulses, and documentation of the color, warmth, sensation, and movement of the pointer finger and the thumb that's distal to the TR band. So leave an oxygen sat monitor on the patient's affected pointer finger or thumb and record that O2 sat every 15 minutes along with your vital signs. A decrease in the O2 sat would indicate decreased perfusion, and nursing would need to act to restore perfusion by taking a little bit of air out of that balloon. Now, how long does the band stay on? The length of time varies depending on what procedure was performed. If it's a diagnostic angiogram with no intervention, the band must stay on for 60 minutes after the sheath is removed by the physician. This part, that removal of the sheath, is shown in the picture above. If the patient had an intervention along with the angiogram, such as coiling of an aneurysm or embolization of a tumor, the band must stay on for 90 minutes. Patients who undergo endovascular therapy for clot retrieval, with or without TPA, also require the band to stay on for 90 minutes. There is a bit of guesswork here, as not a lot of studies have been done in patients that have had TPA. So if 90 minutes is not enough time and you see bleeding, we will teach you how to manage that bleeding as well. When it comes to your documentation, this is what your documentation should look like in SEM. Multiple time columns in the neuro assessment flow sheet, one every 15 minutes, just documenting your assessment of the puncture site and that limb that's distal to the TR band. You don't need to do or enter a full head-to-toe flow sheet assessment every 15 minutes. Just do this one little parameter, just a focused assessment on the neurovascular puncture site. You can modify the row label. It's really helpful to indicate when the angio was done and what site the radial puncture site is. And then your clinical record should look like this in SEM. Note how the puncture site was to the left radius and the blood pressure is being taken from the right arm. Also, you can note that for this patient, there was a change in oxygen saturation and the strength of the distal pulses at 8:45 in the morning. The little box in the top right corner means the nurse right mouse clicked and said enter note to document an MPR specific to this abnormal finding and what this nurse did about it. Here's an example of what a nurse might do and document if they found bleeding at the puncture site and then the later removal of the TR band. It's really helpful to keep all the information about this TR band for your shift in its own little MPR, and then just modify it and update it as your day goes along. So if you were to observe blood coming out of the puncture site, you would make sure that the TR band is placed correctly with the little green dot about 1 to 2 millimeters proximal to the puncture site. You would inject a bit of air into the TR band balloon, about 3 mils of air, to see whether or not the bleeding stopped. The band itself can handle a total of 18 mils of air, but you might not always know how much is actually in the balloon when the patient comes up from angio. It's a bit of trial and error, but they almost never inject 18 full mils of air and leave it in there. They inject 18 mils and then they take out as much as they can to about to hemostasis. So in this example, the bleeding was noted at 8:30 in the morning. The nurse injected a bit of air and the bleeding stopped. This patient had endovascular therapy with clot retrieval and TPA, so the nurse waited the full 90 minutes after the sheath was removed. So they waited until 9 a.m. and the nurse withdrew 3 mils of air, saw some fresh blood come from the puncture site, and reinserted that 3 mils of air so that they got hemostasis again. And as per our policy, they reattempted in 30 minutes. So 9:30 rolled around, the writer withdrew 3 mils of air from the TR band, no bleeding noted this time. So gradually, over every 15 minutes, as per our guidance document, the nurse withdrew 3 mils of air. Once the TR band was fully deflated by about 10:30 in the morning, the TR band was removed. Now they say in the process document to do like a proximal to distal removal, just to maybe avoid um, dislodging the clot that is just formed. So next, the site was cleaned with a bit of dry gauze and a sterile transparent dressing was applied. The patient was also instructed to avoid using their arm for 24 hours and to keep the dressing on for 36 hours. Again, for removal of the TR band, you just need hand hygiene and non-sterile gloves. And again, every 15 minutes, along with your vital signs and perfusion checks, you're going to remove 2 to 3 mils of air until all of the air is out, which you can see in the little balloon there. If you see bleeding, put a little bit of air back in until the bleeding stops, and stall, wait another 30 minutes before trying again. Once hemostasis is achieved and the band is completely deflated, remove the band, clean the site, and apply the transparent dressing. You're going to document an MPR, make sure the transparent dressing stays on for 36 hours, and then you can scale back your vital signs and your neuro assessments. So it goes from Q15 to Q30 minutes times 2, Q1 hour times 2, and then Q6 hours and PRN. Please see the Clinical Neuro Practice Direction Manual for radial arterial angiogram TR compression band for more information about how to reapply the TR band if for some reason you can't maintain hemostasis to the puncture site. And of course, manual pressure is always an option in situations of uncontrolled bleeding. If you have any further questions about the TR band or any of these procedures, please let us know. We're happy to address them. Thanks for your attention.